Hello, everyone. Welcome back to the Physical Therapy San Pedro podcast. This is episode 46, and we are discussing disc herniations, anatomy, symptoms, and treatment. I am your host, Dr. Janae Brown, and I am joined by my wonderful team of physical therapists. And we have a newcomer today. So to my very, very left is Dr. Silverton. He is our new sports physical therapist joining our team about a few weeks ago. Next to him is our dance physical therapist,
Dr. Bay.
And to the right of me is our sports physical therapist that's been with us about 6 months now.
Mm-hmm. Yeah. Dr. Yana.
Yes. So our wonderful team is here to discuss this together, this topic that or this injury that we see often. I actually wrote this blog because I have seen a ton of disc herniations, disc bulges, herniated discs, however you want to refer to it, in my lifetime as a physical therapist. It's been 19 years of a lot of back pain. And so I feel pretty like an expert at it at this point, that I've seen a ton of it. So I feel comfortable talking about it and kind of sharing with you guys some of the things that I have seen in terms of successful patients, which are a lot of our patients, and then just a handful of patients that didn't get huge success. And we'll kind of chat a little bit about what that might be and why that might be, for you guys to listen and hear and learn from us. So we are going to dive in with anatomy, and brave Dr. Silverton is going to start us off with anatomy. So I'll give you the mic. You can have it, and you can take us through what are some of the structures and things that are involved in this particular injury.
When we're looking at the lumbar spine, particularly the low back, colloquially, we have 5 lumbar vertebrae all stacked up on top of each other. The front part of it that takes up most of the weight is the body of the vertebra. On the back side, you have the pedicles and the lamina. If you want to think of it kind of like a pentagonal birdhouse, the pedicles stick out the side, lamina make up the roof of it. Off of those, you have transverse processes that stick out. And then you have spinous process that sticks out the top side. That's typically the bones that stick out of your back as you lean forward. Those are all attachment points for your muscles, so you can bend, move, twist, and what you need. In between each of your lumbar vertebra bodies, you have lumbar discs. In between those are jelly-filled kind of discs that allow for shock absorption. They expand, contract. They are fibrous around the outside, concentric circles, and then in the center, a little bit more towards the backside, you have a nucleus pulposus. It's a jelly-filled substance that adds to a little bit of the shock absorption, and it moves around as you lean forward, backward, sideways. In the middle of that birdhouse that we talked about on the backside, between the pedicles and the lamina, you have a hole that runs from the top of your body, top of your spine, all the way down. That's where your spinal cord runs. And then in between each of the vertebra, you have holes that come out the outside also. And that's where your nerve roots protrude outwards. And then they run out to your rest of your body, down to help you control your legs, so you can feel your legs, so you can move your muscles.
That's it.
Thanks.
Seems really complicated, but it's actually quite simple, but it's complicated too. Yeah.
I like to think how amazing it is.
It is pretty amazing, like that it all works together and makes us move, essentially, right? Walk from it. Okay, that is the lumbar spine. We're gonna, I was thinking as you were talking that a lot of times physicians will, or even us, we describe the sort of the disc as like a jelly donut, like a jelly-filled donut, right? It's a common thing that we say, like, imagine your disc like a donut and there's jelly inside, and then, the jelly pushes out the side. That's kind of what a disc herniation is, right?
Mm-hmm.
So it's a good mental sort of note or image for you guys to think about what it might look like. Okay, so disc herniations are caused by a bunch of different things, and Dr. Bay is going to tell us what those are. What are the causes? Get excited. All right, take it away.
Well, not that exciting is that a good amount of the disc bulges we see just occur from slowly over time, motions building up like poor posture and repetitive movement. But if you're wondering if you have a disc bulge, something that our patients commonly report when they've injured themselves is, okay, I was bending over to pick up something and I felt a sharp pain in my back. I felt a pop. I felt something shoot down my leg, like pain or numbness or tingling. Those are all common things that are reported. We're going to discuss the 3 common specific causes of a herniated disc, and those would include mechanical stress, degeneration, and trauma. So, going back to mechanical stress, this refers to stresses to the body from activities such as bending, lifting, and twisting. So, a lot of doctors will call this the BLT. So, if you've hurt your back, they'll recommend you don't do those things. Don't bend, don't lift, don't twist. BLT. Remember that. So, those motions, bending, lifting, twisting, make our discs very prone to injury. Those are movements that they're a little bit weaker during. Age-related wear and tear is the degeneration component I talked about. Just over time, our bodies unfortunately do not last forever, and some of the structures that Dr. Silverton discussed that make up the disc, the annulus fibrosus and the nucleus pulposus, kind of weaken and degenerate over time. And last is the trauma. If you've had sudden forces to your spine, like a car accident or a big fall, that can cause the disc to herniate as well. So if you feel that you have injured your spine and you're wondering if what you feel sounds like you've herniated your disc, Dr. Yana next is going to help us understand the common symptoms associated with this injury.
All right. So the common symptoms or things you may feel if you're dealing with a lumbar disc herniation include pain, numbness and tingling, weakness, and changes in your reflexes. So when it comes to pain, you'll definitely feel it in your lower back. Could be one side, like right side or the left side. It can radiate into, meaning it can travel down like your glute, maybe your hamstring or your calf, and you may also feel it in your feet. For numbness and tingling, that occurs when that somewhere along that nerve track, most likely the sciatic nerve, is being compressed. And that's when you start feeling sensation changes in either your leg or your foot. You may also experience weakness, so not as strong as you were before the injury in your lower extremities. It could be your glute, hamstring, calf, anywhere along that posterior leg. And then changes in reflexes. So we would figure this out most likely during your evaluation and exam. And that would be in the knee or ankle joints, so less reflexes. Okay.
All right. Sounds good. Short and sweet and to the point. So we like it. So if you're thinking, okay, now I know some of these, know the anatomy, I know some of these causes, I know some of these symptoms. Sounds like I might have this problem. Maybe I do have a disc bulge or disc herniation. You might want to know what the pathway is to getting some help. So you might find that you end up in your chiropractor's office or your physical therapist's office in the beginning because you have somebody on your team and you've had an injury before and you go straight to that person. If you end up there first, then those clinicians are going to take you, like ourselves, are going to take you through a series of clinical tests to sort of confirm that this is the problem. If you end up in your physician's office first, then your physician will do some similar testing. They might order some scans like an MRI or CT scan to see if they can see, or x-rays as well, to see if anything makes them think that this is a disc herniation. MRI is the most common, and that's where we can really see sort of the problem for the most part. And then if your disc herniation is severe, they might recommend that you elect into a surgical procedure to correct that. So that could be a laminectomy, a microdiscectomy, or a disc replacement. Those are some of the options that we have right now in terms of surgical intervention. Or if it's not severe, or they think, hey, let's try some physical therapy first and see if we can get anywhere, because there's very high success rates with disc herniations in physical therapy, then they might elect to recommend and refer you to a physical therapist. Some other options are pain medication, steroid or cortisone injection, and I think that's it. I might be missing one, but those are the common ones that your physician's going to kind of elect in for conservative treatment. So if you end up in a physical therapist's office for conservative treatment, which is a very, very, very high likelihood, and I hope you do, because that's where you're going to see success and where you're going to get to the other side of this injury. Even if you end up having surgery for a herniated disc, a good physician's going to recommend physical therapy and you're going to see us. And some of these things might look similar post-surgical or pre-surgical. So if you end up in our office, the primary thing that we're going to be doing first with you is education. We want to make sure that you are doing the right things at home. You spend so much more time at home than you do in our center here or with your clinician. And so what you do at home really can impact like how you move through your rehab and how you get to the other side. So we want to modify your activities, making sure that you're not doing things that are aggravating your disc herniation. And we want to make sure that you're following your home exercise program and you're doing things that aren't too intense or exacerbating your pain, even within things that we give you for home. We're going to start addressing pain. So there's a lot of different techniques to address pain, and every physical therapist does this a little bit differently. We all have a lot of different skill sets depending on when we came out of school and any additional like learning that we've had over the time of our career. So some of those things could be cupping, taping, electrical stimulation. At one point we were doing ultrasound. We're doing a lot less of that in the clinic now because of evidence, traction, and then manual therapy. So manual therapy is part of our next sort of category, which involves soft tissue mobilization, which is kind of what you guys might think is massage. But when physical therapists are doing it, we're not doing it to make you feel good necessarily. We're doing it to break down the soft tissue and create more blood flow to the area and decrease the tension in the tissue. So it's a little bit different of a method. So we're not giving like a full body massage when you have back pain. We're gonna
What?
It's not happening. Don't ask for a massage, okay? Because we're not giving it to you. But we will touch you. We will feel around. We will see what's going on in there, and we will utilize that information so that we can help reduce the tension in that area or the any restrictions we see. And then joint mobility is something that physical therapists do and chiropractors do as well, working on joint mobilization. I'm sorry. Physical therapists have been trained in sort of those high graded mobilization techniques that chiropractors do, but you'll tend to see it a little bit less in our practice. We are safer when it comes to that. We're a little more gentler. We like to kind of make sure we're not too aggressive when it comes to the joints, and we kind of typically will move on the joints little by little to help release them and release the tissue that's attached to them so that you can get more mobility in your spine. So that's our manual therapy techniques. Fourth is therapeutic exercise. This is our bread and butter. So if you're coming to see us in our clinic, that is the thing that we're really focused on, is getting you moving. So even in the beginning, we're trying to find small things that you can move and feel good with. Specifically with therapeutic exercise and this particular injury, which is a herniated disc or disc herniation, we really want to focus on centralizing your pain and stabilization in your spine. And when I say centralizing your pain, what I mean is that when you have a disc herniation, as Dr. Silverton was talking about earlier, that bulge is going to usually, if it's a bad one, it might bulging and hit one of your nerves. And if it's touching the nerve or irritating the nerve, there's inflammation in that area. That nerve, which goes all the way down to your foot, the sensation, the activation, the information could go all the way down there. It could be irritable. So you might have those numbness, tingling, pain, weakness sort of things happening because of the pressure on the nerve. So our goal is to centralize that. And so the further the pain is down, or the further the tingling is down, or the further the weakness is down, it means it's very peripheral. What's going on is not just impacted like the low back, but now it's impacting everything down the leg. So we want it to come up. So we get excited when we have somebody come in and they have pain and numbness and tingling into their toes or feet. And then the next session they come and they say, I only feel it down to the back of my thigh. We're like, yes, we're making progress because we're getting up towards the back, and we want it really to be local in the back. That's how we know you're healing and you're moving in the right direction. So that's centralization. And a common exercise method to centralize a herniated disc is the McKenzie method. A lot of us learned that in school. Typically, the extension pattern is the thing that helps reduce a herniation. There are other types of herniations that we do see that actually go the other way. They're less common. and they're a little more tricky, but the extension is the primary one that we target with herniation. If the extension method's not working, then we will look for your sort of movement bias. So we'll look for the thing that your body doesn't like, and we're going to go after the things that your body does like and slowly move into that. So you just might not like, you might not like bending forward flexion, but you might not like extension either, or you might not like side flexion. So we're going to go after what movements feel good if it gets tricky and it's not just an extension issue that you're having, or that the extension is what we want to use to get you there. So that's typically how we'll start with stabilization and centralization. Stabilization is just really, and core strengthening can kind of be combined, but they're basically working on tightening everything up in the core and in the trunk. So getting everything in that area to have good proprioception, working on your balance, working on your control in that area, working on firming up those muscles and getting the muscles in the lumbar spine to activate and the core to activate and just sort of support the spine, because when the spine feels supported, it's going to have a better healing process along the time. So those are those are basic things that we start with. And then once we start to see you centralize, once we start to see you stabilize better, once you're walking without pain and moving and functioning and sitting up and standing and doing all those things without pain, we're going to start moving you towards more of a strengthening program that addresses more larger trunk strength things, we might move towards hinging, and we might move towards squatting, and we might move towards, bigger movements, strengthening your lower extremity single leg movements, working on just the full body strength. And so that's the next step. And then the final step is, once we have you strong and all that, is getting you back to sport. So, and getting you back to your activities. So that is a gradual plan that we do. And we work with you to make sure that anything you need to do in your daily life, you're a gym goer, you do CrossFit, you're a strong man or strongwoman, you are a bodybuilder, you run, whatever it is that you do, you play soccer, it could be a variety of different things that you're doing. Your exercise program is the base, but how do we get you back to that thing? We're going to work with you as sports physical therapists to get you back to that thing. So that is what we do. That was a lot. I feel like I talked. Okay, so now we're going to go through our sauce, right? We're going to talk through why we are different, what makes what we do different in our clinic, how we might approach our patients a little bit different. So does anybody have a patient that has a disc herniation or herniated disc right now that you can think of on your caseload?
I do.
You do?
Post-op.
Post-op.
Yeah.
Okay. Why don't you tell us a little bit about how maybe your post-op treatment would look different from like a fresh, like new patient that had a disc herniation and didn't have surgery? What do you think you're doing a little differently with this post-op patient?
I was actually surprised that I was able to start him at a more advanced level, because he actually had like a huge decrease in his pain post-surgery compared to pre-surgery. And of course we were like safe about it, because you definitely want to do the proper load progression. But I could see that the exercises I started him with were just like too simple for him. So we're like already, I think he's been here 3 or 4 weeks now, and we're now getting into the functional movements. Okay. And he hasn't been experiencing like too much soreness afterwards, and is able to like withstand that load. What do you think the reason is? And this is a good conversation, but why do you think he might be doing better than maybe what you thought he would be able to do?
Great surgeon.
Okay, cool.
And then, it could have been like where the bulge was as well. Yeah. And then it just took a ton of pressure off. Like he told me he was limping before the surgery, and during his evaluation, it still was like very like slightly there. But then after working on some isometrics, we got his gait to improve. But overall, I think it was better. He was able to progress more because he's like a very motivated patient. So that was a big part of it too. Motivated. And he wants to get back to what he was doing before.
So he's motivated. I think that's key, right? What about his end surgeon? Very important, because it's really hard to find a really good surgeon who has high success rate with a herniation, period. Like I've found I can count them on my hands that I would refer to, that I've seen good success with surgery. So that's really important too. What about him as his activity level? Was he like someone who just kind of like wasn't
Right.
active?
Before he was very active.
Yeah,
Yeah.
he was very active. And what do you remember the things he used to do before?
Golfer, and I think he also runs. Yeah,
Okay.
but mostly golfing. Yeah.
Running and golfing. So he was active before, had a high activity level. Did he have does he have a physical job?
He does.
Yeah,
Construction.
So physical job. Some of those things play a important role, right? You're already kind of strong, and then maybe I don't know what his mechanism of injury it was, but sometimes that kind of, if I were to guess, I would say it was traumatic. Something he did that was traumatic and then it kind of happens, and you're like, okay, he's got his strength and everything before, but now we just need to fix this quick problem. Was it a traumatic injury?
It was.
Yeah.
Also gym goer.
Yeah.
Gym goer.
Yeah. And so I feel like those are our high success ones, right? Because versus like someone maybe who had had a sitting job and was sitting a lot through the day and didn't get up and take a lot of breaks and went down to bend down to pick up something off the ground and then had a pop in their back, but maybe didn't exercise prior or didn't have a very high activity level prior. That's going to be a whole different type of rehab process and rehab person that we would rehab, right? So that's really good. That was great information. Good share there. What about you? Anybody else have a current?
I don't have any back pain right now.
Yeah. You have anybody right now on your caseload?
Not disc herniations, just more generalized low back pain.
Okay. So somebody give me she gave me a success patient. So somebody give me a non-successful patient that you've had that was a herniated disc patient. If you've had one, because if you haven't, I'll share mine, but and tell me why you think maybe they weren't successful in their rehab and why they didn't actually get back to whatever they were going to do, or maybe they ended up in surgery because PT didn't work for them. Anybody have one?
Yeah, we had one here a couple of years ago, and I would just have to say the case was a little bit more like the opposite of Dr. Yana, where it was someone that didn't participate in regular exercise. And I just remember we couldn't get his symptoms centralized. Even when we tried to do the basic stabilization movements, his pain would peripheralize very, very easy, even though we tried multiple ways of targeting the muscles and trying to decompress things. Yeah. And he did end up going finally back to the doctor and having surgery. We tried your McKenzie method. Yeah. That was a bummer that we couldn't be as successful, but I think that goes to show how important it is to, even if you're not injured, take care of your body, because I just truly believe through the practice I've had that the stronger you are going into an injury, the better your body can heal.
100%. Are you, Dr. Silverton, any shares? Anybody?
Most recently, I had a gentleman that was in his mid-40s, been dealing with back pain since he was in his 20s. He didn't have any surgery at that point in time. I don't think he's tried physical therapy. Just things were just getting worse for him. He was limping, couldn't put weight on his leg, couldn't really bend forward or anything like that. So started him off on McKenzie. Things centralized a bit. He couldn't even lay on his stomach. We had to put 2-3 pillows under his stomach just to get him to lay flat. Gradually got him flat, gradually got him into being able to press up into it. That took already a while to get to that point, considering he's been hurting for about 20 years or so. And then we were getting pretty good results as far as like him walking more normally, him being able to sit comfortably. He had to drive a lot for his work, which was a bummer. But guys got to work. So
the drive. My same patient just told me this week the only time his pain does increase is on long drives.
Driving.
Yeah, pretty common.
Yeah.
So worked with him for a bit. And he just had a flare up. Some of the other flare ups also, which was always discouraging. But worked through it. Still couldn't, after that flare up though, we couldn't get him back to get it calmed down to the point where we were prior to the flare up. So at that point, considering how long he's been dealing with it, I reckon you might want to talk to an ortho at that point. Ended up having surgery, came back to us afterwards. The surgeon hit the nail on the head, we think, and he didn't have any pain going down his leg afterwards, and then started him back on therapy again as far as getting him into being comfortable prone, getting his movement back, protecting the surgery early on, and then getting him back to moving.
Yeah, it's good. I've had, I would say, 95% success rate, and my 5% are people who don't listen to what we tell them to do and don't stop. So, for example, a lot of those are people who continue to work, continue to sit for long periods, drive. A lot of them are like they drive a lot, or they're in the car, drop off, pickup kind of situation. Um, and you, what's really interesting about surgery is surgery, you have to stop. So if you have spine surgery, you have a period, you're not going to go back to work probably for 2 to 3 months, right? So the physician tells you right up front, like, you're going to need to take time off. People know. But with PT, it's really hard to get people to stop doing what they're doing, even though we say you just got to stop doing that. Like, if you keep doing that, or you're going to not ever get better. And I think that's a lot of the time where we see gains too, post-surgical, is there's a rest period, like post-surgery too, where they're just, because surgery, right? You do a laminectomy, you do a discectomy, you still have had prolonged pressure on that nerve. So you still have to like work through all those things that were irritated, like, and the weaknesses that come through it or whatever. So, but people stop, and I feel like that's when they get the healing. So a lot of the ones I've had success with too, they've been in a period of stop, and then we can actually really work through the deficiencies that are there. So, and I usually kind of tell people that up front, like, you're not gonna see the success if you just really don't pull back from things. I'm not gonna be able to help you, because you have to pull back. You have to pull back with a physical job, or but people often won't just stop on unless they have surgery. They won't just stop everything 100%. So yeah,
It's a tough situation because there are financial concerns, they got to
for
work
sure.
and things like that. So
Yeah.
at the very least, if they're coming to me with that much pain and have their back up against the wall, they feel like they have to continue working.
Yeah.
That's where we come into play and try to find out, okay, well, if that's what you got to do, how can we change the way you do it so that way it doesn't suck as much?
Yeah, for sure.
So, okay, are you tight in the hips? Can you bend through the hips more, not through the back? Because if you got to bend, lift, twist, can you bend, lift, twist through your hips and use your leg? Lift with the legs, not with the back.
Yeah, for sure. How do we modify your activity? Super, super good. Yeah. And there's ways to get there. And a lot of them that just listen to us like that, they get there. So, and that's why we see huge success with physical therapy. It's the small percentage that struggle, and need surgical outcomes, or just a really bad herniation that is hard to fix. Yeah. Okay, well, that's all we have for you guys. I hope that you guys took away something and learned something new. And if you think that you're struggling with this, if this sounds like something that you might be going through, hopefully you were able to apply some of the things that we shared here. If you need some help and you need some physical therapy and you're in our local area, we would love to help you. We're in Los Angeles County in San Pedro. So you can come into our clinic and work with any one of us here. We also do telehealth, so virtual therapy. So you can see us online and do our physical therapy with us online. We do that with a lot of patients across the country, even across the world. So that's an option as well. If you are tuning in for the first time, we have 45 more episodes for your listening and viewing pleasure on YouTube and on any listening platform you have where you listen to your podcast. So Amazon, Spotify, Apple, any of those areas, you can go listen and tune into all the great things that we can share with you and educate you on. And if you're interested in doing some online programming from home, we are just starting to build our online programming. We have our first program up on our website that was released this summer at physicaltherapysanpedro.com on ankle pain. So if you have some ankle pain or you're struggling with something not related to your back, but your ankle, that's the first program we've released, and we're going to be releasing more over time. So look out for those things as well. We're trying to give you guys a lot of different stuff in a lot of different ways. So you can also follow us on Instagram and check out kind of what we do in our center here, and Facebook as well. And we do a little bit of posting other places, but those are our primary spots. And I think that's it. I don't think I left anything else out unless you guys want to share anything. Final thoughts? No? Okay. Well, we want to get you back to what you were doing. So hopefully this helped you with your back if you're having some back pain, and we will see you next time. Bye, you guys.